Dr. David Freedman, who will be talking to us about update on vaccines. If you've heard him speak before, you know that he is an absolute leader in the field. And most importantly, he is considered really, he knows the data before it comes out. I think most people feel that way about him. So, but let me tell you, if you don't know about David, he's the founding director of Travelers Health and the professor emeritus of infectious disease at the University of Alabama at Birmingham. He is the founding director of the Gorgas course in clinical medicine in Lima, Peru. He is the past president of the clinical group of FASTMH, which is American Society of Tropical Medicine. He is the co-editor of the textbook of travel medicine editions 1 through 3. He is the associate editor for emerging infectious diseases. And also he's a section editor for Journal of Travel Medicine. He currently serves as managing senior director of Shoreland TravEx. You just heard Rebecca talk a little bit about Shoreland. He was secretary treasurer of the ISTM, which is a huge job. We always underestimate that treasury job. And he has served as, during the Zika epidemic, as one of the 12 members of the WHO International Health Regulation Emergency Committee. He has also served as chair of expert committee on anti-parasitic drugs for US Pharmacopoeia. And for 18 years, until 2013, he was director of the Global Geosentinel Surveillance Network, which he co-founded and currently maintains the largest database of ill travelers available. And you'll hear, myself included, multiple people are part of that surveillance network. And I think, David, I think it's safe to say that you have actually changed the face of travel medicine. You have brought surveillance, travelers as surveillance in as a concept before it actually was. I know you were there at the beginning and people don't appreciate what you've done. I think you've really laid the foundation for so many aspects of travel medicine. You're a wonderful friend, an unbelievable colleague. No one answers emails quicker than you. David, it is my great delight to introduce you to the audience today.
Thank you very much, Christina, for the very kind and detailed introductions. Pleasure to be here for this nice crowd. Before I start my talk on vaccines, and maybe it can be discussed further at the panel, I use GeoBlue, and that's relatively new in the past few years as coverage. You don't need to be a Blue Cross Blue Shield member, and they have partnerships with Bupa and a lot of the international hospital insurance organizations, and take care of a lot of the actual hospital things. Not so much Medevac as international SOS, but they will arrange it for you. But really, they make it pretty seamless, and they have a long list. That's the key thing. They have a long list of cooperating hospitals that just take this travel card that they put out. So I can highly recommend them, and I have no conflict of interest there. I do use them. I do use them personally. So let me go ahead and get my slides up, and we'll get going. Okay, Christina, does that look good? Slides are showing.
It looks great, so I'm going to start muting and stop my video. Great.
Okay,
I'm handing
great.
it.
So, of course, the most important travel vaccine these days is your COVID vaccine. We're not going to talk about that today. Those are my titles. So, from a vaccine point of view, the world's kind of changed. Travel medicine's coming back a little bit now, as those that already do it know. But for many months at the beginning, we found a new location, or I did anyways, had, no patients, no vaccines to give in the clinic. So for the first time in my life, I was out there volunteering, giving vaccines, actually together with my wife, giving vaccines in a parking lot at a large stadium here in Birmingham in the middle of winter. As you know, also, COVID's affected travel medicine, and every time we get out of the tunnel, people start traveling a little bit again, but then we seem to run into a new tunnel or a new wave, and that certainly affected what we do every day. I took this last Friday in Iceland, where I was. That's a segue to say that I have done a bit of traveling this summer. I think it can be, accomplished now. I know Dr. Chen, who's coming up, has done some traveling in Europe this summer. Also, I think the real key is the other place I was in this summer to give a talk was the Dominican Republic. The key really is if you're vaccinated and you go to a country where the population, like Iceland, is extremely well vaccinated, and the case rates are low. Case rates in Iceland now are below 10 per 100,000 per day. And all the travelers that are entering must be vaccinated by definition, or else they wouldn't be able to get in. And all those vaccinated travelers who are coming in, because, when you travel, you're exposed mostly to other travelers, not to the local people. And if the other travelers are tested like you are, it's probably pretty safe to travel. In fact, this is a bit of a paradox. The CDC has all these travel prohibitions for, most countries in the world. But in fact, many of those countries that we're not supposed to travel to have much safer environments than here in the United States over this past summer. Yet there are no travel prohibitions. So I found this past summer the most dangerous place to travel was definitely within the United States, and even traveling internationally, the most dangerous place to travel, the most dangerous exposure I faced was in airports in the US, because while the airlines are doing a good job, the airports are not so much. And I can tell you, every flight I took, I had to take 3 flights to get there. I was stranded in a crowded jetway with a bunch of people before and after I got off the flight, and the boarding gates and things like that. And not all of them would have been vaccinated on the domestic flights. Medical meetings, well, we're still meeting virtually. This meeting I talked at in the Dominican Republic this summer, it can be done. Again, everybody was vaccinated. These were mostly non-Americans, so everybody was wearing a mask, except maybe this guy down here who's cheating a little bit. But with spacing and masking and checking temperatures at the door and knowing that everybody there is vaccinated, I hope that largish medical meetings can start again. Okay, so let's talk about some, this is really more of an update on travel vaccines. I don't have time in 45 minutes to talk about, every single vaccine, everything you need to do in the clinic. So I'm going to assume some familiarity and really just talk to some of the recent events that are going on. 2 of the most recent events are that 2 of the vaccines we've been using, oral cholera vaccine, brand name Vaxchora, and Vivotif, which is the oral TY21A typhoid vaccine, which is commonly used, are currently off the market. The company Emergent, you've probably heard about because of their travails with producing COVID vaccine and the problems with their factory, et cetera. And so they made the decision, since people weren't traveling anyways, and there wasn't that much of a market, they withdrew those 2 vaccines, and there's no telling when it's going to come back, when they're going to come back, and if they're going to come back. These are acquisitions by this company, and they may just either stop or sell off these vaccines. Their focus really is not there right now. All the stuff that's out there has expired, so you really can't find any of those vaccines now. Meanwhile, while this was going on, Vaxchora, for those that had been using it, is now FDA approved for children. The ACIP was supposed to give its stamp on that FDA approval for pediatric use, but has decided that it's off the agenda because the vaccine's not available anyways. So that recommendation won't be in place. I think the other piece of news, though, is that the package insert, doesn't say, because there was no data, how long, when you would need a booster. There's just nothing about boosters there. They said there's only data out to 6 months. It kind of implies, you could want to give it every 6 months if people are at continuous risk. But there is some data now that was just published in 2021 that the immunity is 2 years, at least for young, healthy 12 to 17-year-olds, as we know. And I think we're going to see a lot of this in the future. I mean, I think we've always known that vaccines don't work as well in older people. It just hasn't been that well studied in older people. So it's kind of vague for many vaccines, but I think we're, really seeing the obvious as we're diving into it now, that many vaccines, you can't just say this vaccine is good for all adults. And that's not going to be the way forward. That's just a little bit of a side comment. I think this kind of framework, which is in the ISTM slide set, and Rebecca covered or alluded to, is just important in terms of vaccines as well, because vaccines are certainly part of the standard risk assessment approach right there in the middle, along with some of the other components that you're going to see. So you have to apply your epidemiologic data and what you know about risk, and not just risk in, remember, not just risk in endemic populations, but risk in travelers, because that may be very, very different. And oftentimes there's specific risk in travelers. If travelers just don't have the behaviors or go to the parts of the country where there's risk of a particular thing, their risk is going to be a lot lower than in the native populations. This is always something that comes up in the discussion in the travel clinic, and it's become more of a focus with COVID. And I made this slide for COVID actually for a talk I gave to a company, but I think it's important with respect to any travel vaccine, because somebody will ask you, the patient will typically ask, well, is this vaccine you want to give me 100% effective or 90% effective, or how foolproof is the vaccine? And so, the misconception that arose during COVID, but I think is important in the travel medicine discussion, when you say that this has a 95% vaccine efficacy, it does not mean to the patient when they go on this trip that they have a 5% risk of infection. It means that compared to somebody that's unvaccinated, they have 95%, but not everybody that's unvaccinated is going to acquire the disease. And for many of our travel diseases, the risk is actually quite rare. So I just worked up this example. Oops, I forgot to delete. That's the name of the company. But if you have 50,000 employees, or if you have 50,000 travelers, or whatever, when you vaccinate and it's 2 to 3 weeks later and it's 95%. So according to the incidence rates of, at that time, COVID, but it could be another disease, if no one was vaccinated, you would have 250 cases in your population of 50,000 employees. If you vaccinated everybody, 95% reduction, you would have 12.5 cases out of your 50,000 employees or 50,000 travelers. So the risk for each individual vaccinee in your population would be, as you can see there, 0.025%. So actually very, very low. It's not a 5% risk. And then again, the question, what are you protecting against? Are do you want to protect against somebody dying of the disease? And that's very important when we give, say, malaria prophylaxis, or is it somebody actually getting any symptomatic disease? And that's the debate that we see every day in the media now, but about COVID, but we would certainly see it for travelers. For vaccines, you need to have information on risk of individual diseases in order to discuss that with the patients. And there's a number of sources that are available, and these are the common ones. You can see rabies in the top right and Japanese encephalitis in the top left. You can get information a little less granular than these maps for many of the diseases from the CDC travel page, from a number of commercial services. Textbooks and things like UpToDate tend not to be as up to date especially on the country specific geography, but that's part of what you need to assess in the clinic before recommending or not recommending a vaccine. Remember, behavior is very important as well. You have to have the exposure behavior. So in terms of the actual vaccines, the 3 R's, this is a very common framework, and it's routine vaccines, required vaccines under the international health regulations, and recommended according to the risk to the individual traveler. And that to some extent depends on the individual traveler, and part of your risk assessment is assessing what their tolerance of risk is. Some travelers may say 1 in a million and there's a vaccine, but the disease can kill me. Give me the vaccine. The others will say, well, that's less than the risk of getting hit by lightning. I just can't worry. I just can't worry about that. So, that's a discussion, and that has to do with risk tolerance. I should probably say under required now, not just the international health regulations are from the WHO, and they specifically don't recommend vaccination for traveler due to a vaccine equity issue, et cetera. Vaccines, should be, conserved for local populations, et cetera. So it's not part of the international health regulations, but I mean, de facto, there are so many countries now where basically if you want to go there, if you're unvaccinated, you either can't get in, or if you're unvaccinated, you have to serve a 7 to 14 day quarantine once you arrive and be tested several times, et cetera, et cetera. So in fact, if you want to go there on a tourist trip, especially of a week, you don't want to spend 2 weeks in quarantine. So it's a de facto, requirement, just not a WHO requirement, but it's a de facto requirement. As far as routine immunizations, I'm not going to have time today to talk about these, but obviously, except for measles, but obviously you need to be sure that every single patient is up to date on their Tdap, on their varicella, on their flu, and remember that flu is year-round in the tropics. It's a good time also, not particularly increased risk with travel, but HPV and zoster if they're eligible, and remember zoster is down to age 50 now, and more recently in all compromised adults, even FDA approved now for age 18 and greater for compromised. ACIP hasn't ruled on that yet. They're going to be that they've just talked about that last week, but have not voted on it yet. And again, another routine just to keep on your horizon, 2 new pneumococcal vaccines have actually been FDA approved, Prevnar 20, and this one from Merck, which is a PCV15 vaccine, and they'll be on the market soon. ACIP didn't vote on this yet. They talked about it last week. The bottom line here, I won't have time to go into detail, but it looks like what it's going to be is that, and it's approved for age over 50 from the FDA. What it looks like is that everybody over the age of 65 and all adults that are immunocompromised 18 to 64 will be recommended to have a single shot of Prevnar 20. The Vaxneuvance, which is a 15-valent, is still going to require the Pneumovax 23 in combination, so it's much less practical. So somehow it's FDA approved. Somehow I think the ACIP is going to recommend a preference for a single dose of Prevnar for people that have an indication for pneumococcal, just to simplify the very complicated regimens that we have. Measles is a routine vaccine. I'll just mention you do need to assess measles immunity. CDC does recommend that all travelers, no matter what country they're going to, just to keep it simple, be up to date on measles and have had 2 countable doses of measles vaccine prior to their trip. So if they were born since 1990, they've had a routine vaccine when they were a year old, and then another one preschool. But people born earlier may have variable. If they were born before 1970, they may not have had any measles vaccine, although they may have had measles. And if they're born in between, they may have had 1 dose and not been caught up. Although if they went to university, started university after about 1995, almost certainly they would have had the 2nd dose. Forget about, we'll just these are the American rules. I won't talk about Canadian rules today. So just check on that. And basically that's the rule. 2 countable doses need to get. Also, and I think Dr. Hagman's going to talk about pediatric later, so I won't dwell, but infants age 6 to 11 months should get a non-countable dose for the purpose of their travel, and then just get the routine. It doesn't count because it doesn't have long-term efficacy, but should then get their regular dose at 1 year of age. But very important, it's a very susceptible age for measles. This is the current measles map, and you can see it's still a huge problem in Asia, measles, and in Africa. Not so much in Latin America anymore, but there's a big outbreak because of the breakdown of health systems in Venezuela, and the refugees from Venezuela spread measles all over South America. That's common. That's calming down now, but you can see the list on the left of the current top 10 countries. And I should also say Western Europe is off the list, but there was a wave there in the last mid-decade up to about 2019, 2020. And there was a huge, places like France, and even England, Switzerland had huge outbreaks of measles. And so, whereas we don't usually see people going to Western Europe in the clinic, we did need to see them because they all needed to have their measles status checked at that time, and a wave could come back again. COVID has played a big role. COVID, in one sense, has interrupted vaccination programs in the developing world for measles. So measles is really taking off again in the developing world, but it's prevented travel. And so usually it's introduced cases that cause, large waves and not fully vaccinated rich country populations. That has stopped with COVID. So that's been at least one blessing with COVID. We've lost these waves of measles, and you can see we had some introduced cases in 2019, especially in the New York City area and a couple of other areas around the country, and had record numbers of measles cases. And that's right now there's hardly any measles because there's hardly any travel in the to the United States. Measles immunity, that's the definition. So you can do lab tests. The lab test is not perfect, but it's pretty good for measles. Obviously, lab confirmation of acute disease. So you don't have to vaccinate somebody that has measles immunity, but it's very important. They changed this about 6 or 7 years ago. The acute disease is not an oral history. You cannot accept if there's a physician's record that, they bring in something from the pediatrician and says, yes, this child had, measles 20 years ago, but there's no results of a lab test in the chart, then you're not supposed to count that as having had the measles because, that's just the doctor's opinion. Although, anybody that's seen measles, it's usually a pretty easy diagnosis to make for most of us, but I guess for younger physicians that haven't seen measles, it may not be such an easy diagnosis. This is just a sidelight in terms of travel. One debate that's ongoing about a third dose of MMR vaccine has to do with mumps outbreaks. So it turns out that mumps is less is less effective than the other two components. Maybe 2 doses is only about 80 to 85% effective. So we do have these occasional outbreaks of mumps, especially on college campuses, in supposedly fully vaccinated. So there is an indication if somebody's if there's a local epidemic of mumps, that you can give a third dose to the population to stop the epidemics. I kind of stretch this to travelers. I've only done it a few times, but if you're going to Mexico or Sao Paulo or whatever, and there's a huge mumps outbreak, going there, you might want to think about a third MMR dose because somebody's going right into the current outbreak. And, they're supposed to find out about that because they came to the travel clinic. I think I'm going to leave this out. I saw that Dr. Connor, I just realized that Dr. Connor was talking about hepatitis vaccine, but again, the hepatitis A is like the measles now. If you have a 6 to 12-month-old, they should get a non-countable dose before the trip and then get the regular series after that. Hepatitis B vaccine. Just to mention here, in terms of the imminent traveler, it's always been an issue, how to get them fully vaccinated, especially if they're doing risk behaviors. So, Heplisav is unfortunately with a smaller company that doesn't have the marketing oomph. But really in travel clinics, I think Heplisav should probably be the preference at this point because you can give a full series in 28 days. It's not considered an accelerated series. You can give accelerated series of the standard Hep B vaccines, but then you need to give a 4th dose a year later to have long-term immunity against hepatitis B. And, obviously a lot of people are going to miss those 4th doses. So, giving full dose after, 4 weeks can be very practical way to get around this problem. It is an adjuvanted vaccine. So the only thing I would, that some people are careful about is you don't, because of the increased reactogenicity, you don't want to give too many adjuvanted vaccines on the same day if you can avoid it. And the adjuvanted vaccines that we are concerned about that have potent adjuvants in them are Shingrix, shingles vaccine, Fluad, which is one of the flu vaccines, especially used in over 65s, and of course COVID, COVID vaccine. So that's just worth keeping in mind because your patients may not be happy. And I think in everybody's experience, by far the worst of these vaccines is Shingrix. A lot of people have been knocked out for a day or two with COVID vaccine. It's a lot worse with Shingrix. Okay, shifting gears now to some of the true travel vaccines. This has been voted on and approved by the ACIP at a meeting in May or June. Because of the busyness of COVID, et cetera, it's not been officially published in the MMWR yet, but certainly it's voted and it's pretty straightforward. And I think everybody should be using this. And this is a pre-exposure for your travelers. And I'm not going to, the indications are, high-risk countries, high-risk activities, and, you can check CDC and others, for the level of risk in individual countries. But there are three categories. There are 3 categories now. And so for travelers, and you can see the definition of the categories. So travelers are considered in category 3, so lower risk than the veterinarians and things like that that are below them. But the basic series is now just for pre-exposure prior to the travel is just 0 and 7 days with a full IM dose. This is a little bit different than what WHO says, but these are now the American guidelines. This can be given at any age. And it's 0 and 7 days. And then you can either empirically give a third dose anywhere from 21 days to 3 years later, and they're pre-immunized and considered primed, or you can do a titer. But you can only do the titer between 1 and 3 years. And if they have good titers between 1 and 3 years, then they don't need anything else, and they're primed for life and only need a 2-dose post-exposure series. If their titers are not good, you just need to give them the third dose. So this is very nice, because for your short-term travelers, they just need to come in twice a week apart, and then you can worry about the next trip. You can worry about the next trip later, but if they're going to be doing regular travel, you should certainly tell them to get their titer checked between 1 and 3 years, so they know whether to consider a boost or not. For your long-term travelers, if they're going to live somewhere remote where there's not good access to titers and things like that, usually they're preparing farther in advance anyways, and you can decide with them, it has to do with cost and everything. You can decide with them whether to just empirically give the third dose at 21 days, which is what we previously did. So the fundamental principle here is the data that the ACIP accepted, that a adequate titer 1 to 3 years after your primary series is predictive of long-term, priming. And so that's how these are constructed. The higher risk people either need to basically need to keep testing. So this is in there if they have the 2-dose series. So this may be a cost issue for many companies and occupations and things like that. But really, if you're a veterinarian or a wildlife worker or whatever, just get the 3 doses 21 days apart, and then you don't need to have a regular titer check. This really just says the same thing. Shifting to yellow fever. So after 4 years off the market, yellow fever vaccine YFVax from Sanofi Pasteur is back commercially available to authorized centers. You have to get an authorization from your state health department to be a yellow fever center. The cost has gone up a little bit. The stuff they're shipping now is good for about a year, and the interim solution, which is using this non-FDA approved French yellow fever vaccine under a cumbersome IND thing, has been completely discontinued. So we are back to the status quo on that. Which brings us again to the debate about who needs a yellow fever booster. And this is kind of a summary. There's huge literature on this, but this is a very nice study from the Serum Bank published in the Journal of Travel Medicine from the Serum Bank at the CDC. And basically the bottom line, when you parse it all out, is that about 85% of people, once you get to the 10-year point, only about 85% of normal, healthy people, take out all the HIV, take out all the compromised people. So the neutralizing titers do go, for a developing country, for herd immunity, et cetera, that's a good level. For an individual traveler, it's probably not. a great level, although again, we don't quite know what neutralizing titers mean. So sorry, before I say what I recommend, there was another recent study in 2020 showing that when you're just dealing with young, healthy military, that 10-year thing, or sorry, it's actually 20 years, goes up to 95%. So this impacts, for those who take care or are involved with the military, the average military career is less than 20 years. So from the military point of view, they probably just need one dose, for their entire career. So the US, I didn't put it in the slide, but again, the bottom line on the booster recommendation, according to US guidelines, there are different guidelines in other parts of the world, is that you probably don't need a booster every 10 years unless you're going to be at significant risk. And they define as significant risk is a short-term trip, any trip, so including short-term, to West Africa, which has the biggest yellow fever problem, or to an area where an epidemic is going on. So, if like Brazil had a big epidemic in 2016 and 2017. So there's a huge epidemic going on. People should be boosted every 10 years. And there's also a caveat in there. Again, this is just normal hosts. The other caveat in there is if you're going to be a long-term resident, even if you're going to a low-risk yellow fever, so just a place where there's any theoretical risk, if you're going there for 2 years, you should probably get a booster every 10 years. You should probably get a booster at 10 years. The guidelines don't really explicitly address what you do after 2 doses, but probably every 10 years. Something new is tick-borne encephalitis. So you may not be aware, the FDA has approved TBE vaccine in the US. It's a European vaccine. Just to mention, the TBE is mostly an issue in Western Central Europe, and especially in the former Soviet Union. It's tick-borne, it's in forested areas where there are a lot of ticks. With climate change, this is not 100% up to date. With climate change, believe it or not, the ticks are headed north, not much more so than mosquitoes are headed north. So in fact, there are now, as of last year, there are now 2 separate, it's not marked on this map, there are now 2 separate areas in England that are considered to be epidemic for TBE. And there's also an area in the Netherlands that's considered to be endemic for TBE as of the last couple of years. So it's highly focal. So again, you need good maps for this. It's a summertime disease, like all the tick-borne diseases. The risk factors are outdoors activity, obviously, and even a short trip. So if you're going for a 10-day, one of those 10-day walking tours through the forests of Central Europe, especially the Baltic countries, you definitely need TBE vaccine. I should say this was FDA approved this year. The ACIP wording on this, ACIP is not going to publish till they're going to consider it actually next week or the week after. But the MMWR with the exact wording of what the risk behaviors and extent of exposure and things like that usually doesn't come out till an MMWR is published. Remember, it's a summertime disease. So hopefully by the time we have to deal with travelers next summer and COVID's going to be over and everybody's going to be walking in Europe again, hopefully that wording will be out. So the brand name is Ticovac. It has another brand name in Europe. It's got a huge experience. It was just never previously licensed in the United States. And again, this is kind of some of the wording that I use for this, but we don't have official ACIP wording yet. This is Ticovac, sorry, that should be in there, FASTMH Immune or Ticovac. It's licensed for kids, half a dose for younger kids. It's 3 doses day 0. 1 to 3 months and 5 to 12 months after dose 2, and then you get a booster. You can give it 0, 14 days and 5 to 12 days. And in fact, in Europe, I should mention, in Europe, this is the regimen. This is actually the US regimen here. And this is considered to be an accelerated regimen in Europe, but the FDA accepted this as the regular regimen. So in fact, you can get your doses in very quickly if you need to. Japanese encephalitis, Southeast Asia, South Asia, rural forested, rural pig farms. The mosquitoes breed in the rice paddies, the reservoir is in the pigs. So the risk is when you're near, when you're in rural agricultural areas of most of Asia, the risk varies. It is a rare disease in travelers. Just this period here, up to 2008, there's an actual publication from the CDC. So travel acquired, all the millions going each year to Asia, just about 58 cases in 35 years, and pretty much it's pretty much the same now. The risk countries in particular are Thailand, China, Vietnam seem to be the worst places for that. It's a rural disease. The vaccine, according to the FDA label's a little bit different than the CDC ACIP recommendation, but basically what most of us do is it's 2 doses prior to the trip, 2 doses. You can give the second dose anywhere from 7 to 28 days. It's completely flexible. That's only for adults. The pediatric dosing is still 0 and 28 days. And then if it's a regular traveler or an expat and they're at continuous risk, give a booster at a year. And then they should be protected for up to 10 years or so. We really don't know because the vaccine's only been on the market for about 10 or 11 years now. And there's no further data than this. So if you wanted to be cautious, you might give a person like this a booster of Ixiaro, 10 years after they've had their 1-year booster. And again, just the indications for this: outdoors in rural agricultural areas. And this is for short-term travelers, defined as less than a month or so. And, basically with a couple of exceptions, it's not in urban areas. So if it's a typical urban business, trip, or the mosquitoes bite at night. So if it's somebody staying in cities and just doing day excursions and never outside the city at night, they probably don't need it, obviously, if they're going to an outbreak. And the other thing we run into a lot is uncertain itineraries. We would give it because, if they say, I'm just not sure, I'm going to Bangkok, I don't know where I'm going after that, but I have a month, give it to them, because there's a chance good chance they're going to end up in a high risk rural area at some point in time. Long-termers, give it to everybody. You can't predict where somebody, even if they're an urban expat living in Beijing in a high-rise apartment building, you just no way to predict before they go overseas what their exposure might be during a year or two in China. Meningococcal B vaccines, not recommended for travel. I put it in because confuses people, and we are giving it to adolescents, etc. Of course, if it's somebody traveling for study, they're going to be going overseas, student living in dorms, things like that. You might consider it. One of the problems with the Men-B vaccine that we have now is, this is just to say that even in the US, Men-B is a fairly rare disease, but obviously quite devastating. So the red here is what I'm trying to say is there's actually strain variation between countries in the MenB. And so these two vaccines, the Bexsero and the Trumemba, were really made against specific strains. And it's hard to predict that it would even be effective in somebody going to country X because the strains there may be significantly different. And most countries don't have, except countries in the, most countries just don't have much MenB. 2 per 100,000 people per year is pretty typical for almost every country. There's no equivalent to a meningitis belt like we see with Men-A. I think due to lack of time, I was just going to talk about documentation. Rebecca already talked about yellow cards. We're all familiar with this on the right here. I would just like to say that except for the European Union, these digital passes that are accepted by multiple countries, which Americans can't get anyways, the full European Union thing, they're really stuck. I'm not sure where it's going, and I'm not sure whether I can foresee when there's going to be a digital pass that's accepted by all countries. We are absolutely nowhere close to that. That's all I want to say about that. If you want to know more about travel medicine, Lynn and I and Phyllis Kozarski did a review about 5 years ago, and most of it is still accurate, but stuff in terms of risk and prevention still there. And Lynn and I did this one, and the reason I mentioned this one is just the Mayo Clinic proceedings a couple of years ago. Very, very beautiful table put together by Lynn that really talks about your special needs travelers and, you know, the pregnant and immunocompromised and HIV patients for all the different vaccines and kind of the best thing for these special needs travelers. Okay, I've got 2 minutes left, Christina. I will stop sharing. Oops. Let me see if I can see anything in the Q&A window myself.
I'm right here. Sorry, someone was just walked in. So what is the rule of thumb for measles for someone that has had vaccination of MMR, but now as an adult, there is not immunity to measles? Do you boost time 1 or do you start the series again?
You're not supposed to do. So the bottom line is you're not supposed to do titers. Having had 2 doses is supersedes any titer that you get, because the titer is not absolutely, the commercial titer that you'll get is not absolutely perfect. So you would, if you accidentally do the measles titer, ignore it. Sorry to say, that's the rule.
Okay. Okay. All right. And then the other question was kind of in between yours and Rebecca, so I'll send it to you. It's kind of interesting. Rebecca, I'm not sure if she's on or listening, but hi, there's some suggestion of increased SEs with COVID vaccines, including myocarditis, due to inadvertent IV injection, due to lack of aspiration when vaccinating. Any comment? Aspiration was taught when we qualified in 1990. Any thoughts on this from either one of you?
Well, first of all, CDC for many years has not recommended aspiration before an intramuscular injection. I'm actually not aware of the IV thing. I haven't seen whatever paper. I'm sorry, there's so much out there, so I don't want to comment any further on that. There's no empiric reason, though, to believe that would be, that would be an issue.
Okay, and Rebecca, anything on that? You haven't seen that either, right? I haven't seen it either.
No, I haven't seen that either. And it's, again, unless there was, could just be a sort of case report and I don't know the data or evidence behind that, but it's been a longstanding practice of the CDC not to recommend aspiration.
Okay, thanks, Rebecca.
And there is evidence for that.
Okay, thanks. Thanks. David, for you, and this is an interesting thing because we do this in my clinic and I'd be interested in your response. So many cases in migrant populations where they receive vaccines in other countries, or maybe they don't remember, but got titers here which are low or undetectable. Do you re-immunize them, right? So if they have, like, say, low measles, do you check the titers again? I don't.
After you immunize them? No, I mean, at that point, I would treat them like a naive, once
Right.
you decide they're naive, I would treat them like, a naive person in the US, and I wouldn't do a titer.
I do think it's an important point, though. So every new migrant we see in our clinic, we're actually looking at this now. And we're looking at the migrants that we're seeing in primary care, and we're checking off to see if people actually get measles, mumps, rubella titers on our migrants, which are really low. And we're finding that people don't check them on migrants. So I think it's a really good point, especially when people come over and we see them in the adult clinic where we don't think about routine immunization unless we're doing travel. So I think it's a really good point.
Christine, I just want to add one thing on that.
Yeah.
In terms of in travel clinic too, I mean, people will come in with no records.
Right.
So part of the assessment, even for, people who have grown up in the United States, is if you have an understanding of the US standard of vaccines and when things were implemented, if people went to school and, went to university, high school, it's likely, unless their parents were objectors to vaccines, that they fit into the standard protocol. With older adults who have no records, it's harder to know. So sometimes you do check titers if there's zero records on people, and it's important. And also in healthcare, there are standards. OSHA has standards that you may need to check titers to confirm that somebody is immune, because that's an important part of exposure and follow-up in the healthcare environment for hepatitis B, measles, and varicella, I believe.
Yeah, thank you. Thanks so much for that. One other thing, it says, would you give the whole MMR vaccine to those with low titers? So I assume if it's just measles, would you give the whole MMR? I guess that's what they're asking. Just said, would you give the whole MMR vaccine to those with low titers?
You always give, I mean, the rule is you give the whole dose, always.
Yeah.
No matter what the circumstance is. If there's an indication to vaccinate, you should never not give a whole dose.
Yeah.
There are some considerations that come up, it's like, I don't know, half the dose spilled, or the patient pulled away, and only ended up with half the dose. And what do you do? What do you do then? And that's a more difficult, I think, Rebecca helped me, but I think the rule is if you've given like more than half the dose, you don't necessarily need to repeat it, but it varies by vaccine.
Yeah, I believe that's correct. That you'd have to check that reference more carefully, but that's pretty rare.
Right.
Occurrence. It may happen more in the pediatric population where people just can't hold still. So
yeah, I should mention for people, if something happens, there's a whole section on that in every ACIP guideline, including the COVID guidelines, like mistakes that happen. And there's all kinds of rules for every vaccine, and you can, look them up. Like I gave too few doses, I gave too many doses. I accidentally gave adult instead of pediatric preparation. All those kinds of common mistakes are covered. And in fact, if you I will put in a plug for the immunize.org website. Mm-hmm. Rebecca mentioned it earlier. It's fabulous. And they have a Q&A. They have an ask for every vaccine. You click on the vaccine, and they have an ask the experts. And usually those Q&A formats cover all these common mistakes or inadvertent things that happen.
Yeah, if you have a few minutes, just go to immunize.org and look at the ask the experts, because it will ask questions that you'll see questions of things you may have thought of a long time ago and then forgot to look up. It's actually very interesting. To spend 15 minutes just perusing through those and
it's actually funded, for those that don't know or don't read the fine print, it is actually funded. Their major funding comes from the CDC just mm-hmm. to present something kind of to the public. And the experts Q&A is CDC. I mean, they ask CDC experts. They make up the questions, and then they ask the CDC experts. So that those are all answered according to official CDC policy.
And one other thing, just to make a plug, because one other thing there, especially for people who deal also in their practice with children, and it's a big with pediatrics and parents and vaccine hesitancy and all these issues about reactions. The immunize.org has some amazing resources of how to communicate these issues with parents. And, it's coming to the forefront now with adults with COVID vaccine, of course, because of vaccine hesitancy. So a great wealth of resources on that website.
Okay, there's I think we kind of went over everything. By the way, David, can you just say the insurance someone asked once again that you love?
Geo Blue, like, Blue Cross Blue Shield, Geo Blue, capital G, capital B, one word. Just Google it and you'll get it.
Yeah, I thought you were talking about like an outfit you were wearing or something when you first started. Then I realized it was actually insurance. I got confused. So, David, I'm going to ask you to just peruse the questions yourself and type in case, because there was a little confusion on one. It may be the way I said it. There's just I think we answered almost everything, but if you didn't, David, we'll go down. David, Rebecca, again, thank you. Thank you so much. We have a panel discussion at 10:15. So I actually will do a case, but for those of you that need a bathroom break, you could do a bathroom break on my case. So for those people that are hardcore and want a case, I threw a case in there because I thought we'd have a half an hour, and I can't stand wasting time, as everyone knows. And then for those of you that want to do a bathroom break, it's not a big deal. So I'm just going to do a case right now, and I will share my screen. And Anne-Marie's going to let me know if you can see my screen. Can you see my screen?